Okay, Assalamualaikum warahmatullahi wabarakatuh. Hello, good morning, webinar participant today. Thank you for joining the International Webinar Nursing 2020 and from the organization Global Indonesia Healthcare. And thank you from invite me from the sharing about the dressing safety, a systematic review for wound care management. My name is Asmat Burhan. I am the interstomal therapist nursing, wound care nurse consultant, and medical clinical nursing. And I'm lecturer nursing anesthesia in University of Harapan Bangsa. Okay, let's go. Today, learning objective in webinar. All we this is the study, the introduction, the background, prevalence of the wound in Indonesia, and the dressing tip for all the dressing to use the application for pressure ulcer, for the diabetic foot ulcer, for the surgical wound, and gangrene, maybe, yeah. And the systematic reviews of the dressing in analysis from the meta-analysis on systematic review to the safety dressing to the application and the combination and the effectiveness from the cause the disease from the patient and the clinical case or the evidence-based practice for nursing. Okay, this is the compendium trend in the dressing 2020. This is the hydrogel and the hydrocolloid and the catexomer regarding in the spectrum was the antimicrobial for use the patient in diabetic foot or the pressure ulcer. And the trend in 2020, negative pressure wound therapy because this is the very good for therapy in this the surgical wound and the foam, the polyurethane from the silicone, from the alginate, the versus this is my topic in here. And silver dressing for the resistant for the bacterial or the microorganism from the infection in Indonesia. And the compression therapy for the reduce edema from reduce the infection to external and internal from the patient. And the trend in the trend dressing the 2020 the notrox from the oxygen therapy and the granulox. Introduction, administration of dressing the medication to patient. Okay, this is the introduction. Okay, a wound is the brick in the continuity of the tissue to of the injury of surgery. These wounds can be classification based on the depth, the anatomical structure, and the nature, and the healing, the process, and duration healing. Because this is the very complex in wound, is the acute ones and the chronic ones. And the duration of healing, the 30 day, this is the not done the healing wound. This is the chronic wounds. Okay, and based on the nature, namely the abrasion from the skin and the contusion, the skin breakdown or the skin trees, the very the theory, the new concept theory for the skin tears from the Kevin Wu and Dimitri Opri. And the incision for the surgical and the laceration, open and the penetration, puncture and sepsis for the cause uh, wound. And why wound care is the action to kill microorganism because this is the first the wound and the short long this is the healing wound this is the microorganism the very big okay and the very the control infection and the acute wound are the wounds that held according to the time and the time of healing acute wounds that are the often and accurate are the after surgery, as in the doubt or the trauma and birth. according and the Cat Harding 2009. And the chronic ones almost dead do not heal according to normal the psychological and the anatomical the process from the inflammation, maturation, proliferation, and the maturation, and the stake of the time of the year. Once they are the considered chronic if they not so progress for more than 20 days from the framework. Sorry. This is the from the framework overview in the chronic one. Chronic ones is the complex the disease. This is the core example from the chronic ones. This is the pressure ulcer or the pressure injury, and DFE, diabetic foot ulcer, diabetic foot infection, diabetic foot osteomyelitis, and gangrene. This is the very complex lower extremity for wounds. Okay, this is the overview in Parker 2015. And the prevalence from uh, wound association in America conducted a study of the incidence of wound in the world based on the cause the disease. The increase from the first, the Turkey and Europa, the 17%. Okay, and Indonesia from the number three, the 30%, and India 14%, and Canada, USA for the 10%. And the very the decrease, this is the South or it's the Africa. Okay, and the percentage in the million shows this is the very big. This is the surgical ones. This is the 62%. This is the all the case from the wound. This is the very cause the surgical wounds. In surgical wounds, the cause the infection or the chronic wounds if do not healing 30 days. Okay. And the prevalence of wound in Indonesia is the chronic wound, the 7.1%, and the second, and the trauma for or injury, the 40.9%, and the diabetic foot ulcer, because in Indonesia the patient are faced the research from the Ministry of Health Indonesia 2015, 14 and 15 until 15. This is the very good from the diabetic, the increase from the diabetic case, 13%, and the pressure ulcer from the hospital, the 30.13%, and the decrease very low, the 1.80%, and colostomy for the colorectal cancer from the surgery, the surgical or the surgical, the colorectal cancer. Okay, dressing objective. This is the function from the objective. Remove the tissue and the phoric object and practical. Remove of the wound base in the condition and wound base from the wound. This is granulation and the particle objects and the microorganism from the necrotic or slug. This is the very good from the trauma and pre-simple, and the bandage from the remove of the tissue. And bandage can control the incidence of the infection or the protect the wound from the trauma and the bacterial infection, because it's the patient from the urine and the infection from the external from the wound base, and the internal from wound base, not the external wound base. This is the very good from the management control from the bandits, and reduce from the edema from the intracellular or the extracellular in the plasma from the lower extremity, and able to retain the moisture. Very good. You you must management the moisture. I think if you the control and the moisture from the wound, this is very good from the management next management from the dressing, evaluation, the assessment from the management the next. And speed up the wound, the healing the process. Yes, because dressing very to correct from the wound healing the process because the support growth hormone and the keratinosis, melatonosis, oxygen, and nutrition from the mechanism from the increase fibrinogen from the fibroblasts and the increase from the keratinosis and epithelialization from the angiogenesis. And the absorbent, the flight from the exudat seromiosa, from the exudat hike, and the easy to use and reduce pain. Yes, dressing uh, application for easy to use, no hard to use. Okay, and is the from the wound care. It is the reduced pain from the primary or the secondary dressing. And the prairie wound protection, yes, the erythema from edema, from the maceration from the periwound skin, this is the management control. And the odor, the control, because there is the cardiac iodine from maybe the polyhexid or the kilbab or the optidine from the odor control in the patient. Because the no, do not odor control, this is the very good from the wound base, yeah, or the wound, no, do not infection. Okay, the dressing selection, the parameter, the dance tool, health worker, financial, caregiver, and the critical treatment. It is a readiness tool. This is the very good from the after you the patient, you the prepare from the tool and for the foundation assessment for holistic care from the wound or the patient and the health worker to use the increase for the competition in wound care. Then to do the and competence in the diabetic foot ulcer, competence in reduced infection control, and the caregiver. Caregiver very the problem in complex in the patient incontinentia, fecal, and urine. This is the cause the dermatitis incontinent associated on MIST. This is the pressure from the sacrum. This is the callus and the callus from the nutrition and oxygen do not use the peripheral. This to cause the pressure ulcer in the sacrum or the decubitus. And the financial, this is the very important to support and family and support the patient because do not you support from financial this the treatment do not okay. Instead dressing the process. This is the moisture balance and the autolysis debridement is to remove the tissue, necrotic, and the particle, and the slug, okay, and microorganism. And the first the process the wound healing. Okay, this is the algorithm how to use a wound dress. Okay, this is the one, the wound dressing, your the examination for was wound-based examination from the patient you, maybe the beta distinction assessment wound tool or the photography for wound or the technology for wound. And did you result from the examination for data objective for the patient, your the analysis from the management primary dressing. Remember, primary dressing and secondary dressing different, very different. So not your application. Okay, the primary dressing. This is the hydrogel, cardiac zinc cream, and alginate. And the secondary dressing from the foam, transparent film dressing, and the polyurethane, negative pressure therapy, and maybe the dressing for the absorbent. And this is the very the ecosystem from algorithm to uh, use the dressing application for patients. Tip dressing, the prior to the 1980, cancer was the first the choice in wound dressing. And after the 1980, there was a significant change with the various types of the semi-occlusive dressing, okay, that they support the concept of the moisture balance, okay, and 1990, 2000 until the 2020, more than the 3,500 types of dressing in the world in now, and the dressing from the hydrogel, hydrocolloid, the polyurethane, silver, cadexomer iodine, negative pressure wound therapy, and hyperbaric oxygen therapy or the oxygen therapy, and the compression banded, we analysis in today in webinar. Okay, this is the meta-analysis and systematic review the safety of hydrogel. This is the author, the Liu Jusang from the China. This is the 20 journal from the RCT and the mass control trial. This is the Resicobias from the GBI journal, the Bring Institute. This is the very good form heterogeneity from the journal and the meta-analysis when healing times on the diabetic foot ulcer. And this the confidence interval is 0 and the diamond is the uh, 0 until minus 10. This is the confidence interval from the upper lower the intervention, the very not 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 long the intervention is the from the diamond is the very good. And the p-value be 0.0001. This is the until the effect size from the intervention the very good. However, is the donor the significant from the intervention in diabetic ulcer. And the traumatic skin injury, the very good. This is the this square the 93.59. This is the fourth journal Chan Huang Zhang Zhang and the 40 in the traumatic skin injuries the overall effect size the 1.919 p following 0.05. This is the very good from the parents from the safety hydrogel to use to traumatic skin injury. This the diamond is the very effect size. This low the effect size from the intervention. And from the surgical wounds, the very good. This is the surgical wound. The diamond this the short term. Okay, short term from the mid difference from the surgical wound, the very good, and reduce the fun and blue 2013 and 2017. This is the very good uh, 0.018. The p-value the 67%. This is the very good intervention for the surgical wounds or for the maintenance from the surgical wounds. And the pressure ulcer, this is the same, the very good. Because this is the confidence interval from the one, the confidence is JA from 95%. This is the diamond, this is the positive. Okay, this is the positive, the effect size, the very good from the effectiveness from the safety hydrogel. And the meta-analysis result, the recent burn wound healing. For wound burn, this is the effect size to low. Okay, this is the very good. And I'm sorry, this is the my patient. And the diogen and gene, the ratio, the favor the experimental and the favor to control the very good from the experimental. And this is the very good from the diamond, the gift from effect size the one, and but effect size the slight the effectiveness from the safety from birth. And the analyzer, the treatment includes the wounds, quarantine adverse reactions such as the dryness, raining pruritus, and the fever when the significantly reduced, and the minimize secondary injuries and the alleviates pain, reduce from pain, and generating alcohol feeling, and by the protecting and post peripheral nerve terminals. This is the sensation for cold for you the application from the hydrogel. And the forum important, the warning, hydrogel dressing are the supposed to be applied single rather than the combination with the other. And therapeutic and that's when the use in the combination there, the effectiveness and safety cannot be evaluated from the individual dressing. And the very good from the effectiveness from safety dressing. And this is the clinical case from the this hydrogen in my cases from the slug and the diabetic food. This is the GD from the sugar, the increase to 491, and this is the one the used application from hydrogel. This is the very good, but this is the fixation together with its fixation from the reduced edema. Okay, this is the meta-analysis and systematic review from hydrocolloid treating pressure ulcer in adult patient. The author, the Kaminsky from the Poland and Russia. Okay, this is the analysis from Prisma from the journal. The journal result acting the process analyzed. And this is the criticism journal from the table. This is the very good. And the similar Vaseline from the journal. Okay. This is the pressure ulcer from the healing. The seven journal. This is the very good from the ratio from the confident interval 19.5% from the funnel plot. This is mainly abrasion and the diamond from the one. This is the result very different, significant from the pressure ulcer from healing. This is the long intervention and the effect size. This is the stabilized, and from the results. Is the pressure ulcer healing the red? This is the very good. The positive from the result. This is the meta-analysis. The from the three journal, both and the section the 2012. This is the very good from this intervention long day to day from the 0 for the 0.15 and the diamond the very good effect size, the big effect size from the intervention from the pressure ulcer. And the adverse events, this is the very good. And however, this is the not good from the adverse event because maybe the cost increase from the patient, the many uh, from the pressure ulcer and the hydrocolloid. And result from the meta-analysis, the hydrocolloid have the until it's been regarded and the gold standard from the prevent, do not use the healing prevent standard the pressure ulcer in the clinical practice. And the science they have not the future of the skeletal dressing. And the hydrocolloid dressing are the made of non-adherent high density, waterproof, and highly the absorbent the material then easily removed by saline or the storage in water without any pain. This is the very good from the reduce pain, reduce pressure ulcer. because I think the waterproof, the very important form to preventive the water and the urine from the fecal is this the post patient, the post the CPA, and the bed rest total from the intensive care unit. This is the choice dressing for the prevent the ulcer in the intensive care unit or the inpatient bed rest total. And the Sox dressing has the antimicrobial activity based the structure and the volumetrically. And the very warning in important are not intended for healing exudative wounds. This is the hydrocolloid, not the absorbent in dressing. Okay, and hydrocolloid they use the patient the stake one wound. Okay, and this the stake one, stake two, three, and four. Okay, the impermeable to gas and the cause the inflicted odor after the removal of the dressing. Confirmed the greater efficiency and hydrocolloid revealed the confirm the advantage and the over the competition one. This is the very you remember according to some the researchers when choosing a substable dressing. Okay, and the clinician should take into wound the symptom, clinical practice, and patient preference, and the cost the interventions to you increase the quality of life the patient quality of increase the time from the patient and the cost treatment of the patient. This you use the nursing or the doctor to use the hydrocolloid. This is your the competence and the knowledge and reference from the use the application from the patient. Okay. This is the application from the application hydrocolloid. This is the very easy for your use the application to reduce and preventive from the pressure ulcer or the pressure injury because the composition from the hydrocolloid, the CDC or and the antimicrobial in the composition from the hydrocolloid. Okay, this is systematic review polyurethane. This is the versus the calcium alginate resin. I tomorrow I the analyst from the alginate, but I am the source and one article the very good from the share your the participant today. The polyurethane versus calcium alginate dressing for split thickness skin graft donor systematic review and meta-analysis for surgical wounds. Okay, this is the analysis from Prisma and the journal and the research for journal. This is the figure two. Uh, Quantitative analysis different pain from the after polyurethane. This is the very good the effect size. This is the calcium alginate and the polyurethane. This is the effect size in the select the effectiveness and the calcium alginate the breaks the effectiveness. This is the this is the proof from the study mean the parents. This is the result the good from intervention calcium alginate and statistical the difference in Spain from day 5 day polynutrient dressing. This is the calcium alginate very good. Okay, and 40 10 the application from easy the application very easy from the alginate very good from the oh sorry the very good from the polyurethane. Okay, this is the 4 years the polyurethane and the calcium alginate very good the positive. This is the zero heterogeneity from the p value is 0.02 and this effect size the 0.447. This is the until the one. This is the very good from the effect size from the polyurethane. And very good from the reported polyethylene dressing. This is the very good polyethylene because this the similar baseline from the intervention do not long from the short-term in the intervention for patient. This the effect size from the calcium alginate is very good and polyethylene the very do not the significant from to reduce pain. And in indication hygiene at all the NRS to aid in the patient stratification are revealing that what not significant different. Though not the significant from the to dressing. And easy removal according the staff the according the hackers the use the numeric rating scale from the pen from to access the assessment or removal the staff the perception of the case of dressing removal between polyurethane and the alginate dressing this is the same and the addition and similarity hygiene from the font that's polyutilizing from the change with the time the 34.30 days the very good calcium alginate and polyurethanes this is the very good this is the table from the study polyurethane dressing this is the healing for the 30 days and the calcium alginate of 14 days and the figures from the polyurethane dressing the 5.50 dash and the alginate the 80 the extra zero the 11 dash. This is the result, the proof. Uh, Calcium alginate do not use to the healing and they use alginate to remove pain and they use the healing from the healing in pressure ulcer or the diabetic or the chronic wounds. This is the very good polyurethane. This is the point in the journal. And the conclusion, the polyurethane dressing are more the four belt compared to the calcium dressing, mimicking STSD are the associated with the improve the patient the comfort, healing, higher scar assessment score, and with the correlated and intensity, easy of the application and the effects. This is the very good from the two dressing for the healing and no do not the significant from the healing. This is the statistic from the meta-analysis, the very good from the healing polyurethane. But from the healing and the wound pain, this is the same from the alginate on and the polyurethane. This is the clinical case for polyurethane. Okay, this is the visit 1, 2, 3, 4, 5, 6, 7, 8, 9. This is the very good from the management from the exudate, management from the granulation formation, from the wound healing. Okay, the systematic review of the sulfur AG, sulfur the treatment, and the sulfur impregnated dressing for the healing of the leg wound ulcer and the systematic review meta-analysis. This is the journal from the 17 from the journal 1, the RCT, and the Prisma from the analysis from journal the rest, BS from the GBI quantitative result, and RCT journal L3. Okay, this is the value the result for forest plot from the coherent methods. Okay, this looks from the forest plot. Meta-analysis sulfur fragmented study. This is very good. Okay, non-silver not bad, not bad. Yeah, this is not very good. And the for the silver, this is the short long intervention, the very good 0.5 effect size the big, and the heterogeneity for the patient and from the journal 0.18 the effect size. This is the upper lower. This uh, not long, not long intervention. Okay, and from the wound size reduced, this is the very good. Okay, this is look the table or the figure 3. This is the upper lower effect size and diamond in the positive lead. Okay, this is the proof result from the analysis uh, favor from the silver very good for two wound size reduce. This is the very good from the epithelialization support and the granulation from increase the keratinocyte and melanocyte from the and control or the kill from the microorganism. If you are reading for the journal from effectiveness the sulfur tracing and the mean difference from the healing rates per day meta-analysis. This is the very good. This is the result from the proof and the effect size the very the big and diamond the zero. This is the significant difference from the silver and non-silver from the control and intervention from the experimental group and randomized control trial from the short-term intervention. This is the zero, maybe would no, not 0.2, 0.5. This is the very good. That's the overall the effect size, the 0.47. This is very good. Okay. And the final port result from methane is this is the similar baseline from the eggs, from the journal, from the inclusion, from the include from the journal. This is the flux study, the use one size, the reduction, the similar, do not the external from the point in this the picture. Okay, this is the effect. The partial edge, the first experimental on talk and group is povidone iodine gauss dressing. This is the wound healing, the mean time to heal, wound size reduction, and of this wound dip were statistically significant between the group and the 2 weeks. And the mean time to heal in the body group was approximately 40 days. And the chronic wound healing at the 8 weeks. And the bed also is significantly from the silver tracing. And this is the versus algorithm, the calcium dressing, pressure ulcer, national pressure ulcer, artificial penal grades. 3 until the 4, this is the sacrum, the pressure ulcer, healing the perimeters complete with healing. This is the use the silver dressing. And decrease in area wound based and the wound size reduction from the periwound skin and healing related the short term. And only when healing was reported and the significant the p value is 0.025 in the different from the uh, non-silver and silver tracing. Okay, and the wound size, the very the all the journal. This is the result from the size one reduction there increase in the significantly has experimental group from the healing the process and the size one. Okay, this is the from the size from the silver dressing effect size on top of reason to provide the evidence that the silver implemented do not use the implemented from the silver dressing and you use from the silver single silver do not silver all the silver in dressing and the products, improve the short-term healing with an ulcer and long-term effects from an ulcer. And the important for you is the my message. Do not if you research from culture from the patient, the microorganism, and research uh, from resistant from the bacterial or the microorganism. This is the very good from your application silver. and due to collaboration from the doctor surgery. And the clinical trial data with longer term follow-up types. Okay, this is the clinical case from the silver dressing. This is the very good from the diabetic foot ulcer. This is the the ischemic and neuroischemic from my patient. In this, the healing for 12, 12, 12 the intervention for the weeks. And the systematic review context summary from the Kevin Wu from the Ontario, Canada, and similar from the Prisma flow diagram mapping from the number of the records, the include and the feature, result from 13 the journal. Number one, the figure three reduction for the debris, and after 6 until the 8 weeks, the child experimental group. This is the very good from the hydrocolloid from the reduce the infection. This is the uh, effect size. This is very good positive, and the diamond in 10%. This is the research to provide the very good from the cardiac iodine from the reduced for infection control. And the CIOD group as the shock or the standard wound care group ulcer reduction after the 8 weeks. This is the same, the very good. Uh, but the not significant from the reduced from the infection. And figure the six, the complete healing, the important, the CIOD, this is the very good. The CIOD, this is the diamond from the two exercise and the intervention short term. This is the time and the until 0.5 minutes from the fever shocks. And this is the use the choice from cardiac iodine from the use the management control infection from chronic wounds. Okay, the treatment, the 60 weeks, we compare to the shot, the 60 weeks, the treatment, this child allowing the 12 weeks intervention with child to 7% to reduce infection and the healing from the ulcers. And reduction in the cellular debris from shock and the purulence, this is the reduction of the post-purulent and removal cellular debris or the uh, practical from the wound bed preparation and the wound-based wound. And the statistical, the significant difference between meta-analysis, the very good reduced to post and the reduce the first assessment by visual analog 6 until 8 weeks. The ZOE p-value is 0.001. This is the analysis for the difference for child and SOC. And reduction in wound the burden, significant reduce in wound pathogens. This is the very good kill from the microorganism, the antimicrobial from child intervention. A significant reduction in the focus, the Staphylococcus aureus, the p-value is 0.001, different for SOC. Okay. And reduce in pain. This is the very good design from the cardiac somaria to reduce pain compare all the dressing order. And the side of the reduction following 6. And the starting a significant reduce in pain from the 6 weeks from 6 until 18 weeks, they reduce from pain the patient. And the wound healing area reduction and wound healing, the both saw the 66 reduction in ulcer area in the 12 weeks, and the significant higher of healing the compared and SOZ from the significant the p-value 0.353. And the health strength is significant from the reduced the phenolics ulcer on the CIOD. And SOZ, the weeks 1, 2, 3, and 4 do not use the reduction for healing. This is the very good from the antimicrobial spectrum big from the microorganism. This is the option choice from the use, the management control from contamination, from the clinical contamination, critical colonization, and the spread from the systemic review, the spread. Okay, this is the figure 6 from the choice and research conclusion. Treatment with child should be considered as part of bed preparation and treatment protocols. Okay, this is the very good from the catechsomer iodine from you prepare wound bed preparation for the condition in the necrotic or the SWOG or the management infection control from the first you treatment for wound care until you the final wound care for or the wound healing or healing the wound. And the infection management protocol, this is the very good for the use the standard operational procedure from the patient and result the translating observation from the clinical research and the clinical practice. And the clinical study from the catexomeriotine is 0.9%. This is the very good. This is the day zero. This is the very good from the necrotic and slug infection by biofilm. This is the very good. This is the day no day zero and day the 2020. This is the very good from the wound bed preparation. And the week from the diabetic foot ulcer. This is the day week 6. Week 6. This is the very good from the granulation 100%. And the diabetic foot ulcer week 8. This the use the calcium iodide. This is the very good from the healing from the diabetic foot ulcer. This is the important for you, the diabetic foot ulcer, to use the control and sugar heavy 1C, to use the sugar blood and your the lifestyle patient and the insulin, the treatment, and you reduce from the compression therapy for the reduce edema and interstitial from the patient, and do the examination from the management AB from the ankle brachial index and the two brachial index from the management vascular and the lower extremity, and systematic review and negative pressure wound therapy. And the ZENS eligibility criteria for the student include this the inclusion the very good. This is the from the journal. This is the very good from the about sharing the exploration from the include the study. The patient with the secondary healing and the study intervention negative wound therapy, not negative wound pressure therapy. They exclude from the journal and the control infected standard wound therapy. And the patient relevant the outcomes, the mortality, wound closure, advanced events, amputation, pain, leg, health, quality of life the patient, and the physical the function. And it depends on the how to need for care, the timing of rejection, and the publication in language and in English. This is the eligibility for the plasma for the analysis by step incomplete and the journal for the X. And the figure 2, the meta-analysis for intimation from the NPVT or the SWT, if the confidence interval, the very good. But if this is the result from the meta-analysis, the positive for negative pressure wound therapy with the effect size 100% and the odds ratio 1059, uh, the compare from the standard wound cares. Standard wound cares is the 10, the journal is the very good. And the means from the NPVT and NPWT and SWT. This is very good from the negative pressure wound therapy. This is the overall effective estimation wound healing from the journal. And second, the picture from the figure 3, the fluorescence plot the wound healing index, not not the significant difference, okay, from the SVT. But in the negative pressure wound therapy, this is the very good reduce wound healing. This is the short term and the intervention in the Acosta. This long intervention and the Bueller, Curtive, Liana C, and the first is the very good, the short term, the intervention, and the effect size, the very small from the journal. And the effect size, the score, the P value is 0.005. This is the effect size, the confidence interval 90 per 19 5, the percent confidence interval is the very good from the reduce from increase healing from the wound chronics. And 3, the from the picture and figure 4 in the journal, this is the very good for the NPVT. This is the short-term intervention, one the until 30% of ratio and 60.07. This is the surgical wound closure in the 6 weeks. This is the very good from the statistic result and use the standard wound therapy. And this is the choice wound option from the surgical wound, do not use from the chronic wounds. And in the chronic ones, you debridement, the first you debridement, and you before you debridement, you the control from the infection uh, with the application from the codex iodine before the you debridement and the you the wound care then with the control infection, do you use the negative wound therapy? Because this the journal, according to journal, uh, negative wound therapy do not use direct, but you use negative pressure wound therapy before you debridement and the control infection and the granulation, the very good. Because the negative wound therapy is the absorbent from the exudate and the increase, because the vacuum or the pressure negative, this is the granulation and the keratinization, melatoninization from the increase from the highly from the angiogenesis from the healing the process granulation and epithelialization. Okay, this is the very good from compare. This is the very good from the NPVT, from the reduce from the estimation from wound healing. Okay, this is a significant difference between the wild effects, the words that prove the greater effect and PWT on the time to healing. This is the very good to use the short term and healing from the day to day. And the Davis was a statistically significantly effect for the activity 6 weeks, the means from wound healing. And time to wound healing and all the surgical wound closure in this 9 study. This is the very good from for the surgical wounds to use the application negative pressure wound therapy because do not use the debridement and you the focus healing, granulation, epithelialization, pus, and infection for the biofilm, and the very important to use the epithelialization. Implication for the future research. Due to the various definition of the wound, the cluster in the different times of the data collection or the missing information on the times item. Now in conclusion, by me with the graduate, the sustainability of the wound closure. The systematic incredibly clearly defined of wound healing, adverse event, and health-related quality of life for patient increase. Okay, and the closure wounds healing by secondary intention, like a hospital stay in answer the shorten. This is the very good for the patient do not hospital care and long day, and this mortality reduce, adverse event reduce, and amputation reduce, pain reduce, and health related quality of life increase. This is the very good from the patient to increase the quality of life. Clinical case and POT. This is the picture number one, my patient, and this is the from the Calvé. This is the figure with the vacuum assisted closure or the PICO. This is the very good from the patient laparotomy. Okay, okay. This is the systematic review of oxygen wound therapy from the diabetic foot ulcer arterial insufficiency. This is the 10th journal, and the Prisma from the analysis journal from the criticism from the critical appraisal from GBI, the 9 from the for the journal, and the forest plot the showing hyperbaric oxygen therapy minor amputation, the very good. This is the not significant from the control amputation because this is the picture from the risk difference from random, the confidence interval, the 95% ultra seal diamond. This is the effect size very slack effectiveness from the control, and from the heavy outing do not. Okay, and the figure 4, the hyperbaric oxygen therapy in the mean healing time. This is very good from the heavy OT. This is the form do you look result from the confident interval, the positive in the heavy OT from the long day intervention. And the effect size very small and stable. And the heterogeneity from the G square, the p-value is 0.90%, and the test from the overall effect size point 0.1930. This is the very good. And the mean difference for the oxygen therapy on the mortality, same. This is the very good from the heavy OT, from the figure 40, figure 4.5. And the important from the use the heavy OT or the heavy hyperbaric oxygen therapy, the 90 minutes pressure between until 5 or 7 days a week. If you after use the HBOT for the 7 days with the duration from the 19 minutes done the result, you use the collaboration for the doctor podiatry and heavy auto to complete the ulcer healing. Not the study the distance between the below above the knee amputation for major amputation. Do not research from the use the heavy OT for to reduce from the amputation and reduction of the ulcer size, ulcer tips, which the provide and the outcome in the review and the circuit analyze the patient with the outcome. A significantly lower mean age and significantly larger mean size and to adjust their meta-analysis. And vascular intervention, the vascularization in the 23% of the patient in the heavy OT group and 28%. This is the very big from the control group from the amputation and the vascular problem. And the TTPO2 in the Helida group and the 142 millimeter heterogram, the confident interval, the 90%. And the statistically significant mean difference. And the completion of the treatment that describe the 100% completion of the treatment using the 30 decision and the 40 to the 60 decision. And an NT from the randomized control trial, the 7 the confidence interval, and the major the amputation. Healing the time divided and median times the wounds needed to fully heal and saw a significant difference between heavy OT and control group. And the mortality from the heavy OT reduced 80.3%. And from the increase from the mortality do not use the heavy OT 15% in the control group in the quantitative analysis from the TGPO to vascular intervention and ulcer healing, very good from the hyperbaric oxygen therapy. And this discussion from the benefit about the interim and the lower amputation rates and entry of the 7 short did against all the patient relevant outcomes. When the healing the order from the attending and the completing the heavy OT form session and primarily focus the amputation from the increased quality of life, reduce the cost and the mortality for patients in the diabetic foot ulcer or the chronic wound and affect the regions. And the conclusion from the journal, systematic and meta-analysis from the heavy OT, this that adjuvant do not primary wound care. Okay, heavy OT improve major amputation rate, but no wound healing. Okay, DFO and the POD, diabetic foot ulcers, and the peripheral artery occlusive disease from heavy OT as standard adjunctive treatment. Okay, this is the very point. Remember, okay, this is the clinical case from the oxygen therapy from the visit 1, 2, 3, 4, 5, 6. This is the one oxygen therapy one that's 100%. Okay, this is the message for me. You analyze from the oxygen to you the toxic from the patient, and you analyze from the oxygen wound therapy healing process in the wound therapy or the patient. Okay, analyst from the you use the application hyperbaric wound therapy. And the final from the journal, the compression therapy, effect of the compression bandage on the healing diabetic foot ulcer, a scoping review from me, Asmat Burhan, and the Fitru Arafiati, 2020 to 20. This is the very good venous blood circulation in the legs. Knowledge on the therapy be carried out with the standard to patient because it can the partially affect the quality of life of the patient and reduce health care cost patient. This is the very important with with me. The examination from the assessment of dietic very important. Evaluating very big and the including location, size, septic, edema, exudate, and infection, and the basic quality of wound. This is the very good use the compression therapy. And from the ankle brachia, and that from the vascular for the lower extremity, healing that assists the applying for layer bandage. The diabetic foot wound are various in healing time, but venous flow and the arm was quickly, and the therapy was not the fund in the patient, and the wound had the ankle brachial index below 0.822 pain. Do not you use the compression therapy. This you use the compression therapy result from the failure from the ABI to 0.9 until 1.30 millimeter hydrogram for the ABI, and from the TBI from the 35 from the millimeter hydrogram. Okay, and the edema, the shortness of the edema arterial blood system, AB between from the December from the speak for you. And the treatment compared to visually the circulation was not during the surgery without the significant reductions from the AB, TBI, and SPP. The pressure dressing is not invasive nursing therapy because this is the intervention non-invasive. You can intervention in patient you and the private practice or the hospital, and the effectiveness and the improve the healing the person the diabetic foot once compared with the therapy applying the secondary dressing cause dressing. This is the very good and the healing process the period 12 weeks after the comprehension therapy. Okay, after you use the compression therapy, healing the diabetic foot ulcer from the AV and TBI, the usually normal from the vascular is the 12. Okay, and this is the very good from the compression therapy uh, in management from the diabetic foot ulcer or the chronic from the gangrene, diabetic foot ulcer, diabetic foot infection to reduce the infection from the external and internal from the patient. This is the clinical case, my clinical case, the compression therapy, the visit 1, visit 3, until visit 12, and the timers concept. This is the support, the compression therapy, and use the control from AB and TBI vascular from the sugar blood. And this the visit 3, the same. Visit 5, the same from AB and TBI vascular EDS, and the visit time uh, from the patient, the condition from patient is very good. Sugar blood 157. This is the wound healing, the process. This is the very good edema from the reduce and the granulation from the maybe 7-5%, and the epithelialization 25%. And the visit 12, this is the very good from the wound base and the epithelialization from the 75%, and the granulation from the 90%, and the growth of oxygen and collagen stress for arginine and cadexomeriodin, and support the compression therapy to infection control wound extremities and reduce from the edema macerasi to increase the wound healing the patient. And uh, remember from the compression therapy, this is the secondary dressing, and the wound base focus you the moisture, alginate, and calcium, iodine, growth nutrition, vitamin, and protein fixation, and the growth oxygen and collagen, and the concentration therapy to control, reduce edema, and reduce from the intracellular from the new normal and the vascular from the lower extremity. This is my reference. This you the reading more my paper and journal from my reference. And thank you. I hope you all the participants today you have about material with me and use the application for you the hospital, and you use from the private practice from the nursing because this is the very good from the dressing to reduce pain, reduce costs from the patient, and increase from the wound healing, and increase from the size wound and infection control. This is the very good. Thank you very much, and thank you for your attention. And any question?